Prostate cancer is the second most common cancer in American men. 1 in 9 men will be diagnosed with prostate cancer. September is Prostate Cancer Awareness Month, which allows a very special opportunity on the Prostate Health Podcast to help raise awareness and empower men in taking charge of their health. 2020 has certainly been an interesting year, to say the least, but we can't forget that prostate cancer can continue to be life-altering and a major factor in millions of people's lives every year. The PSA, or Prostate Specific Antigen blood test, continues to remain a useful test for prostate cancer screening. For Prostate Cancer Month, we take a dive into the Prostate Health Podcast archive to pull out a fantastic episode from the vault of Season 1 of the podcast, episode number 2, where we discuss the importance of the PSA, a man's check engine light, with Dr. Judd Moul, international prostate cancer expert from Duke University. So stay tuned. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. Again, I am excited to have Dr. Judd Moul join us today on the Prostate Health Podcast. Dr. Moul is certainly an expert when it comes to prostate cancer. He joined the Duke faculty in 2004 after a career in the U.S. Army Medical Corps, mainly at Walter Reed Army Medical Center. He is a retired colonel and noted researcher and clinician in the area of prostate cancer. He has authored and co-authored more than 275 scientific manuscripts and book chapters. He served as the editor for Prostate Cancer and Prostatic Disease Journal and is a popular speaker and lecturer, having been visiting professor and keynote speaker throughout the U.S. and the world. Dr. Moul, welcome again to the show.
Thanks very much, Garrett. It's a pleasure to be here with you.
So just as a side note, this wasn't by design, but I discovered chatting with Dr. Brantley Thrasher, guest of our introductory episode of the Prostate Health Podcast, that you were one of his senior residents while he was an intern and really turned him on to urology.
Yeah, I was so blown away when you mentioned that. He was an intern when I was, senior resident at Walter Reed. And thinking back on those days, it's pretty amazing that a lot of military urologists from that era went into academic urology. And we were primarily at peacetime, and, folks could really focus on urology. They gave us academic opportunities. We weren't so pressured for RVUs, so there was protected time for research. And so I have no regrets. I spent 22 years in the Army, and then I've been blessed to have the second career at Duke. But yeah, Dr. Thrasher and I go way back.
I thought that was pretty neat. So, well, thanks again for coming on. So we'll get right into it regarding our episode today on the PSA, or Prostate Specific Antigen, which is really kind of a man's check engine light. So Dr. Moul, what is a PSA?
So the PSA stands for Prostate Specific Antigen. It's actually a protein that is produced by the prostate gland and leaks into a man's blood circulation. Every man has some PSA protein in his blood. However, the PSA blood protein increases when a man has diseases of his prostate, such as prostate cancer or an infection of the prostate, or when the prostate gland becomes enlarged. And I like to talk to patients as when they get a little bit older, that prostate starts to leak the PSA protein, and depending on how much it's leaking out is what we measure as far as the PSA test goes.
Sure. So this PSA, can you tell our listeners, is this something we've just always had available, or when was it introduced?
So I'm smiling because I'm old enough to remember the pre-PSA era. When I started as a resident in the mid-1980s, we didn't have PSA. And I can still remember when PSA first came out, it was in the late, 88, 89. Originally, it was like a really sophisticated test. It was actually done first in nuclear medicine. So we would initially, the blood samples would actually go to the nuclear medicine department, and it was a really some kind of sophisticated assay that had to be done in nuclear medicine. And that lasted, I guess, for about a year. And then eventually it went into the regular labs. But initially it was kind of a wild, wild west because there were multiple companies making the PSA test and there were no national standards. So for the first couple years, it really depended on where a man had the PSA test done. If it was in a certain hospital that used a certain assay, you might get one result and then you might get a completely different result in another hospital. And then Dr. Stamey, Tom Stamey, who was a famous urologist at Stanford, who was one of the early pioneers, he came up with PSA standards. And eventually all hospitals and all companies who made the PSA test, they used the same standard aliquot, if you will, to standardize so that most hospitals would get roughly the same number.
So you said you kind of have the experience of being there before the PSA era. You mentioned one of the conditions that can make that PSA go up is prostate cancer. And so from a prostate cancer standpoint, so prior to the PSA, we really didn't have the opportunity then to treat men with curative intent, correct? Or even screen for prostate cancer.
Well, yes and no. Before the PSA test, we were all taught how to do a good digital rectal exam, a prostate exam. And in that era, a man knew that when he was going to the urologist or going to his doctor for a men's health checkup, he would get a digital rectal exam to check the prostate. And at Walter Reed, we were very close to Johns Hopkins. It was just 25 miles up the street. And so we had collaboration with Hopkins. And the classic teaching back in that era was you wanted to pick up what they called a Jewett nodule. Dr. Hugh Jewett was a famous urologist at Johns Hopkins in the 1950s and 60s, and he was really the one that talked about having in those days they called a stage B1 or B2 nodule, which would basically in today's terms be localized early stage prostate cancer detected by a lump or a nodule on the prostate. And we were trying to find these guys when the nodule or the lump was isolated in the prostate and not outside the prostate. So the DRE or digital rectal exam was a key component of screening before the PSA. And then another test, and I know, Dr. Pullman, you're too young to remember this, but there was a blood test called prostatic acid phosphatase, which was before the PSA test. And that they tried to use that for screening, but it really never panned out as far as a screening test. It was useful to help determine if a man had advanced prostate cancer, but the prostatic acid phosphatase would get done, but it was not anywhere near as sophisticated as PSA.
Sure. And you mentioned some of the other things that can cause an elevation in PSA, such as an infection or prostatitis, and really an old trend, which is no longer recommended in the absence of a urinary tract infection. But did you actually see a lot of men being referred on into you that had been placed on an antibiotic to try to bring down that PSA? And is that something that you still kind of see with some of the earlier primary care providers?
Yeah, in fact, I don't like to see that. I think we in urology, we've really tried to get away from that. But you'll still, sometimes what will happen is the gentleman will go to his primary care physician. And, of course, now the primary care physicians have all abandoned the digital rectal exam. At least at Duke, they don't do rectal exams anymore, which I think is unfortunate. So they get a PSA and it might be mildly elevated. And sometimes they're reluctant to send the patients maybe to a urologist right away, or even more troubling, sometimes the patient has to wait too long to get in with a shortage. And so they'll say, well, sir, maybe it might be a little infection in the prostate artificially driving the PSA up, so we'll put you on some antibiotics. But in urology as a specialty, we really frown on that, simply because overuse of antibiotics, especially overuse of, say, the fluoroquinolones like Cipro, is a real problem in the United States. And if we have the primary care doctors giving Cipro or Bactrim or some antibiotic kind of empirically or just willy-nilly to these men, that's not a good thing.
And coming back to the prostate exam or the digital rectal exam, certainly an exam that men are really not excited about getting. and even had some patients say, well, can we just check the PSA? And then if that comes back normal, then only do a rectal exam if the PSA is elevated. Can you kind of talk to our listeners about how that is still important in combination with the PSA?
Absolutely. I mean, I'm passionate that a good prostate exam is really valuable because a urologist or even a well-trained primary care physician can examine the prostate and get a pretty good general sense if the prostate's enlarged or not. And the biggest reason for an elevated PSA in men, middle-aged men, is not prostate cancer, but a prostate that's enlarged, producing a little more PSA. And so the challenge you and I face as urologists in practice now is that since the primary care physicians don't do rectal exams, they don't have any way to contextualize that mildly elevated PSA. Whereas in the old days, or even now, if a doctor really knows how to do a rectal exam, he or she can sense the size of the prostate, or if the PSA is just mildly elevated and the prostate's enlarged, maybe we don't necessarily need to jump to a prostate biopsy or sophisticated other testing. So again, a digital rectal exam is really important to put the mildly elevated PSA in context of the size of the prostate.
And Dr. Moul, as you're well aware, there are many different guidelines and from various organizations in regards to using the PSA for prostate cancer screening and just prostate cancer screening in general, as well as what kind of quote unquote cutoff levels for additional testing needs to be used. Now, do you have a preference in terms of any particular guideline that you like to refer to for prostate cancer screening?
The current U.S. Preventive Services Task Force guideline is the one that most people will at least know because it's been so controversial. And that would generally say that men between 55 and 69 should have a PSA test done every 2 years. Now, and I think that's a good start. I think that's better than no PSA testing, although in our practice in North Carolina, we have a large population of African American men. And so we generally will start testing at 45 or 50 in all men, but specifically in African American men. And then I continue to test selectively beyond age 70 for healthy men. The U.S. Preventive Services Task Force, they really pin it down and say the only really good data we have says that men between age 55 and 69 benefit. However, I tend to think that high-risk men with a family history, men who are African-American benefit, say, a decade earlier, starting at 45. And by the same token, there are a ton of healthy men between 70 and 80, or even higher than 80 in selective cases, who probably deserve periodic PSA testing, because we really don't want to, harm those men above age 70. And just this arbitrary cutoff at age 70 doesn't make sense to me.
So, and we talked a little bit about the U.S. Preventive Services Task Force recommendations, and actually looking back, and some of the general public may not realize this, but kind of back in 2012, where they had actually recommended against screening average risk men for prostate cancer. And because of this, I think you may have seen this too, we started to see kind of an unsettling trend with millions of American men not getting a PSA or prostate cancer screening. And with this, some really believed that this was a disservice to men. So what was your initial reaction back in 2012 when you heard this recommendation?
Well, I think like most urologists we're in the trenches taking care of men with prostate cancer, and none of us who work in the cancer field want to see men show up with advanced prostate cancer. We would much rather treat it early. The genesis, or the reason why the U.S. Preventive Services Task Force made these recommendations, unfortunately, is also partly our fault. In that era, in the early PSA era, from say about 1991 until 2012, when these recommendations came out, we really had not yet figured out how to risk stratify prostate cancer properly. And so we really didn't understand that not all prostate cancers need to be treated. So what happened between 91 and roughly 2001, that decade, there was a huge volume of men treated for prostate cancer, and many of these men were low-risk men that had treatment, and some of them were harmed with side effects. And so the U.S. Preventive Services Task Force, I think, primarily was reacting not to the PSA test, not to the screening part, but the downstream consequences, meaning there was over-treatment of low-risk prostate cancer. And as you know, that's completely changed in the last 5 to 10 years with the understanding that low-risk prostate cancer doesn't have to be treated in many cases, that active surveillance is now being widely embraced by urologists. So it's a completely different era. Nevertheless, between essentially 2008, because even back in 2008, the U.S. Preventive Services Task Force said we should not screen men 70 or older. And then in 2011, they came out with a draft guidelines saying we shouldn't screen anybody. And then in 2012, those guidelines were published. So you could argue starting even in 2008, we saw some harm. Then the harm really accelerated in 2011 and 2012. And now we've seen quite a number of publications coming out in the last year or two showing us that there was a reverse stage migration, that between, say, 2011 and 2018, the rates of metastatic prostate cancer, not surprisingly, started to increase. And now new papers this year showing that the death rate from prostate cancer is actually going up. And so we really need to reverse this trend. We need to do smart prostate cancer screening by using, molecular markers, using other risk stratification, and we now recognize not to overtreat low-risk prostate cancer and very low-risk prostate cancer.
So again, the good news that the task service did reverse their recommendation. But would you say now, it seems that you kind of alluded that you would agree that urologists now are doing a better job in determining, who really needs to undergo further evaluation for an elevated PSA? And do you kind of think we're kind of headed in the right direction now in terms of prostate cancer screening?
I think we're heading in the right direction. I mean, there's still work that needs to be done. For example, I think the U.S. Preventive Services Task Force needs to recognize that not all men age 70 or older are created equal. And they need to soften their stance on an arbitrary hardcore cutoff on PSA testing at age 70. That's number one. Number two, the U.S. Preventive Services Task Force really needs to recognize that African American men with a family history, and even men with hereditary genetic factors are at increased risk for prostate cancer at a younger age, and needs to soften its stance on the age 55. So on 55 to 69, I like what they've done. I think generally doing a PSA test every other year between 55 and 69 makes sense. They just need to tweak it on the front end and on the back end, in my opinion.
Well, certainly you've definitely given a lot of just great, valuable information there for the general public. Any other parting words or any other kind of words of wisdom for our audience in regards to the PSA?
Well, I think men need to be advocates, and men need to take some responsibility for their own health care. And if that's not the man, it's his wife or his significant other. And I would say this, for the patient, the PSA is just a blood test. And we just need to recognize there's little risk in the blood test itself. It's making sure you have a good doctor or set of doctors or team of doctors who know how to interpret that PSA. And if you're not sure or not necessarily comfortable with what your primary care physician is saying, ask to be referred to a urologist and especially maybe a urologist who has a lot of experience, managing men with prostate diseases, so that you can get just a better understanding of your own individual PSA level and what it means to you in the context of the size of your prostate and your urinary symptoms.
Well, so in summary, the PSA, or Prostate Specific Antigen, while not a perfect test, still serves as a good initial check engine light, so to speak, for men. Dr. Moul, we really appreciate you taking time joining us today on the Prostate Health Podcast. I think you've really given our listeners a lot of valuable information today that can be used to help empower them in regards to their prostate health. So thank you again.
It's been a sincere pleasure, and I appreciate your taking the lead on this podcast series. Thank you very much.
Thanks again.
Thanks again for joining us today on the Prostate Health Podcast.
Now, do you have an upcoming appointment at the urologist office? Maybe you're scheduled for a biopsy of your prostate or just received the news that your biopsy was positive for prostate cancer and now have an upcoming consultation to discuss options with your urologist. You may be wondering, how should I prepare for these appointments and what should I expect? Well, I've partnered with the Prostate Health Academy to create a free What to Expect guide that will help get you up to speed as you prepare for your visits. This guide includes checklists of what you need to bring and how to prepare. This guide includes what to expect with 3 different scenarios, including your initial urology clinic appointment, a prostate biopsy, and prostate cancer consultation. To receive this free guide, simply go to www.prostatehealthpodcast.com/clinic. Again, that's www.prostatehealthpodcast.com/clinic, or you can find the link on our podcast website at prostatehealthpodcast.com. I want to thank you again for joining me here at the Prostate Health Podcast. Subscribe to the show on iTunes, Google Play, Spotify, or wherever you listen to podcasts. And please share it with a friend who may find this podcast helpful. We'll see you at the next episode.